Kia ora koutou and talofa lava everyone. Welcome to tonight's Goodfellow Unit Webinar on herpes zoster in the immunocompromised patient. I am Dr. Hazel Fuyava. I'm a GP in West Auckland and I work for the Goodfellow Unit. I will start by introducing our two speakers for tonight who are here with me. First, we have Dr. Joan Ingram. Joan is an infectious disease physician with an interest in vaccines and vaccinations. She is a medical advisor within the Immunisation Advisory Centre at the University of Auckland and an infectious disease physician at Te Tokatu Mai, Auckland City Hospital. Her passion is the prevention of ill health with vaccinations and supporting those who do the mahi by providing information and supportive advice. So welcome, Joan. We also have with us tonight Dr. Edwin Reynolds. So Edwin is a general practitioner working in public health with a background in research who trained originally as an immunologist before studying medicine. He is a researcher and senior medical officer at the National Public Health Service in the Northern Region, as well as a medical advisor to the Immunisation Advisory Centre for the last 15 years. The webinar tonight is sponsored by an educational grant from GSK. The content was developed independently by the Goodfellow Unit and our expert speakers. So I will now hand over to Joan to start her talk. Thank you, Joan.
Called Joan Ingram aho, and as Hazel said, I'm talking about herpes zoster in the immunocompromised patient. So I don't have any conflicts of interest, and this session was commissioned for the Goodfellow Unit and funded by GSK, as Hazel said, but I've had no involvement in the commissioning or the development of the materials. Has been done by me. So my outline today is I'll first talk about the epidemiology of herpes zoster in those with immunocompromise, the clinical picture, and then the effectiveness of the recombinant adjuvanted vaccine, Shingrix, the safety of it, and then practical issues regarding its use. The first point that I think is worth emphasising is that immunosuppression is increasing, and I'm sure you all know that. But here you can see in an American National Health Interview Survey performed in 2021, 6.6% of adults aged 18 or older had current immunosuppression, compared with 2.7% in the previous survey done less than 10 years previously in 2013. So quite a considerable increase. 4.4% have had an immunosuppressive condition, 3.9% were taking immunosuppressive medication, and nearly 2% had both. And as you can see, the prevalence is higher in women than in men, and rates are highest in those aged 60 to 69 years. Just a quick reminder about the virus, the varicella zoster virus, which is a human herpes virus, and as you know, causes both varicella or chickenpox and herpes zoster or shingles, and I'll use the terms interchangeably. After the primary infection leading to chickenpox, the virus establishes permanent latent infection in the sensory dorsal root and cranial nerve ganglia. Then years to decades later, when immunity drops below some unknown critical threshold, the virus reactivates, damages neurons, causing pain, and spreads to the skin through the peripheral nerves, causing the typical unilateral vesicular rash in a dermatonal distribution. Cell-mediated immunity is critical to maintain latency, so it's obviously not surprising that shingles is more common in those with immunocompromise. So let's talk about the epidemiology in this group. This is a large study from the UK. It involved 4.4 million individuals, around 7% of the UK population. And in this cohort, immunocompromised represented 17% of the study population. The overall rate of incidence rate of shingles per 1,000 person years in the immunocompetent population was 6. But you can see the rate increases with age, particularly over 60 or 65, and is highest in those over 70. On the left here, you can see the incident rate per 1,000 years increasing with age, and the rate being higher in females than in males. On the right slide, the immunocompromised curve shows increased incidence rates, but at the older age groups, the risk in immunocompromised is fairly similar to the older age groups in the immunocompromised free population. So do remember the high risk of shingles in your older patients over 70 years of age. We really wish the vaccine was funded for those groups, not just people who are 65. From this paper, you can see the incidence rate per 1,000 person years for various 16 different groups. And the highest rate in this paper and all studies is those with after hematopoietic stem cell transplant. And I do apologize for all my abbreviations. Other groups that have an increased rate are those solid organ transplant recipients, those with hematological malignancies, rheumatoid arthritis, HIV, end-stage renal disease, polymyalgia rheumatica, and SLE. And I believe that Pharmac used the data from this paper to help guide their decision when deciding who to fund the vaccine for. All these groups have an incidence rate greater than 10 per 1,000 year. And other groups such as inflammatory bowel disease, multiple sclerosis, and psoriasis are closer to the immunocompromised free group, although other immunodeficiency conditions and other immunosuppressive therapies are also above 10. I've got a few other papers that show really similar findings, but a lot of them come to more recent time periods. This one is a systematic review of data published in the United States up to 2019. Again, hematopoietic stem cell transplant recipients have the highest rate, and hematological malignancies in solid organ transplant recipients. In this paper, solid tumor malignancy came out quite increased in people living with HIV. This paper looks at a number of databases in America and looks at various autoimmune groups and compares them with the healthy rate. And in this one, SLE comes out as the highest risk amongst these types of patients, also rheumatoid and inflammatory bowel disease in this study was higher than in many other studies. Psoriatic arthritis, psoriasis, and ankylosing spondylitis were lower, and gout is a little higher than healthy, as were diabetics. This paper is a literature review of the incidence of studies in Europe and the UK between 2002 and 2022. So again, quite a contemporary one. And once again, stem cell transplant, solid organ transplant, hematological malignancies have the highest rates. And there's no question about these three groups having a considerably elevated rate. Rheumatoid arthritis, you can see a range between studies up to 21, PMR and SLE, HIV and solid organ malignancies, all raised. And in the same paper, a slight increase, a lesser increase for ulcerative colitis, Crohn's, but also some increase for asthma, COPD, again, diabetes. And in this study, a slight increase in depression, multiple sclerosis, and psoriasis. There are conflicting data regarding the question of whether biologic agents give a greater risk compared with non-biologic therapies for those with autoimmune diseases. In this study, when adjusted for age, sex, glucocorticoid use, and indication, the risk of herpes zoster was significantly greater for people receiving monoclonal anti-TNF antibodies, such as infliximab, B-cell targeted therapy like rituximab, and JAK inhibitors when compared to conventional synthetic disease-modifying drugs. However, in a retrospective VA cohort study in patients with rheumatoid arthritis, those who received treatment for either moderate disease, so agents such as methotrexate, azathioprine, and cyclosporin, or severe disease, such as the TNF-alpha inhibitors, were all at increased risk of developing herpes zoster. We know calcineurin inhibitors, such as cyclosporin and tacrolimus, used after solid organ transplant, inhibit proliferation of T and B cells. And mycophenolate, azathioprine, methotrexate, and many chemotherapeutic agents impair both T and B cell proliferation. So the American Academy, ACIP, at their meeting in 2021, discussing the use of shingles vaccines in those with immunocompromise, concluded that immunocompromised populations are a very heterogeneous group within and across groups and among one individual over time. They felt it was not feasible to define every possible immunocompromising condition or medication combination, nor was it possible to define high-risk subgroups based on the drugs. So they think it was important to consider broad recommendations for immunocompromised populations. Now, thinking about the clinical picture in those with immunocompromise, it's very likely to be more severe. There's often a higher incidence of post-herpetic neuralgia, for example, in patients with leukemia, 14%, and lymphoma, autoimmune conditions, including rheumatoid arthritis, 9%, but 4% in the general population in this study. They're more likely to have complications. So you know the complications, things like ocular complications or neurologic complications and bacterial superinfection. It's more likely to disseminate cutaneously in immunocompromised and immunocompetent hosts, and visceral dissemination, which is extremely rare in immunocompetent people, occurred in 8% of prospectively untreated immunocompromised hosts with herpes zoster in one study. And finally, people with immunocompromise are more prone to recurrences. This is a study from Canada where they looked at the incidence of hospitalization and emergency department visits for herpes zoster in immunocompromised and compared them with immunocompetent adults between 2002 and 2016. Those with immunocompromised accounted for 13% of the hospitalized adults with zoster, despite being only 3% of their population. And their risk of hospital-attended herpes zoster was higher than immunocompetent, the incidence risk ratio of 3, and ranged from 2.6 for those with solid tumor malignancies up to 12 times higher in those who had a stem cell transplant. And the risk of any complication was higher for the immunocompromised, as was the risk for higher disseminated zoster. Across their study period, 35% of immunocompromised had a complication, compared with 26% of the immunocompetent. So this is people rocking up to hospital, so it is a higher rate in the immunocompetent as well. More were admitted to ICU, 4% of those immunocompromised, compared with 1%, and post-herpetic neuralgia in this study developed in 8% versus 5.5%. Death within 30 days of their shingles discharge was 5% in those with immunocompromised and less than 1% in those without. I'm sure you know the management. Just to remind you, it's all in health pathways. You would check for complications such as ophthalmic, which would need referral to an ophthalmologist. As you know, antivirals hasten healing of cutaneous lesions and decrease the duration and severity of the acute neuritis and reduce new lesion formation if they're started within 72 hours. But in immunocompromised, if they were continuing to develop lesions rapidly, you would consider starting it despite the 72 hours having passed. And you might also want to prolong the course in somebody with immunocompromise if their response is delayed. And you would have a lower threshold for referral for intravenous treatment. Of course, pain management is vital in preventing transmission to others, keeping the rash covered until it's crusted to reduce the spread of the virus from it to those who are susceptible, and particularly to other people with immunocompromise. Just to remind you that we're recognizing increasingly the other effects of herpes zoster. It causes a release of pro-inflammatory cytokines, which can trigger endovascular inflammation and potentially lead to rupture of atherosclerotic plaque And in addition, there's evidence of an actual viral vasculopathy, so a toxic effect on the vasculature. Several studies and meta-analyses have shown an increased risk of stroke. It's 1.9 times higher in the first 30 days, and that continues, it drops off, but continues to at least a year following shingles. In addition, numerous clinical studies have shown it raises the likelihood of experiencing a myocardial infarction. It is associated with subjective cognitive decline, and a systematic review and meta-analysis has found vaccination is associated with a reduction in the risk of dementia. So it's not just the acute episode and its sequelae that are important with shingles. Now getting on to the vaccine. So it's a adjuvanted, recombinant varicella virus glycoprotein E subunit non-live vaccine. And glycoprotein E is an abundant viral surface glycoprotein. It contains an adjuvant with 2 immunostimulants, QS21 and monophospholipid A, which the adjuvant is designed to enhance the cellular and humoral responses. It's given in a 2-dose schedule, ideally 2 to 6 months apart, and it stimulates robust and persistent varicella zoster virus specific antibody and CD4 T cell responses. As you know, it's funded for all people at the age of 65 years, unfortunately not when they're older. It's recommended for anyone from 50 years of age and individuals with immunocompromise from 18 years. So this is the new funding since August the 1st. 2 doses for people 18 years of age or older with any of the high-risk conditions. So pre and post hematopoietic stem cell transplant or cellular therapy, and they're the top risk group. Pre or post solid organ transplant, those with hematological malignancies, people living with poorly controlled HIV infection. Early in the HIV epidemic, the rates of herpes zoster were very high in those living with HIV. But with the advent of good antiretroviral therapy, the rate has dropped considerably, but it is elevated compared with the general population. Pharmac has chosen to fund those with poorly controlled HIV infection. It's not tightly defined, but I would say people with a lower CD4 count, particularly those below 200, but probably below 350, or those whose virus is not controlled because they're not on treatment for whatever reason. Those with end-stage kidney disease, primary immunodeficiency, and then those planned or currently receiving disease-modifying anti-rheumatic drugs, including synthetic, biological, or conventional synthetic, for 3 conditions: polymyalgia rheumatica, SLE, and rheumatoid arthritis. So these agents for these patients, but not these agents for other conditions. So now turning to the how well the vaccine works. So there were 2 pivotal pre-licensure phase 3 randomized trials known as Zoe 50 and Zoe 70. Zoe 50 included people over the age of 50 and 70, those over 70 years of age. And the vaccine efficacy in the trial was 97% with a median of 3 years follow-up for the Zoe 50 and 90% for those in the Zoe 70. And this is the Kaplan-Meier curve from one of the papers. So in a controlled study, a very, very effective vaccine. Post-herpetic neuralgia incidence amongst those people who'd been recipients of the vaccine but went on to develop shingles didn't differ from the rate in placebo recipients. So the vaccine has benefited preventing shingles, not the post-herpetic neuralgia itself. Now, since then, we have recently had updated data on the long-term follow-up of these Zoe study participants out to 11 years now. And you can see continuing good protection. It was 82% at 11 years. So this is very much more effective than our previous live shingles vaccine that this one has replaced. And here you can see the T-cell responses remaining very stable out to 10 years. So there's a continuing 6-fold increase in the CD4 T-cells since vaccination out to 10 years. So this suggests that the vaccine is going to continue working well. Real world effectiveness in one study from America with 1.74 million people found an effectiveness of 2 doses of 86%, 80% for those aged 80 and older, which is a bit different from the study where those in the older age bracket did have good, very good protection. And obviously those with immunocompromised were excluded from the initial trials, but I'll get onto those. Another real world study found that giving the second dose after 6 months didn't impair the effectiveness. The vaccine efficacy for those who received their second dose within 180 days at a median of 90 days after the first was similar to those vaccinated beyond 180 days. And vaccine efficacy for 1 dose was 57% out to 6 months. So we do know it's important to have 2 doses to get that higher protection. So turning our attention to those with immunocompromise who were excluded from the initial trials, we have some studies that I'll show you now that have generally been funded and partially authored by GSK. So the first one looks at the vaccine effect in those with autologous stem cell transplantation, and it was a good sized study. They were given the first dose 50 to 70 days after their transplant and the second dose 1 to 2 months later. And the vaccine had 68% vaccine efficacy in this controlled trial. The incidence of neuralgia was reduced because the incidence of shingles was reduced, and other complications related to herpes were reduced, 1.6 in the vaccine recipients compared with 7 per 1,000 person years. The duration of severe worst herpes zoster associated pain was reduced. And importantly, unsolicited and serious adverse events, potentially immune-mediated diseases and underlying disease relapses were similar between the groups at all time points. This is not a controlled study. This is just looking at the use of the vaccine in allogeneic hematopoietic stem cell recipients in a much smaller study, and they didn't receive the vaccine until 9 to 24 months after their allogeneic transplant, so later than an autologous. And the incidence of zoster was lower than in historical controls. However, there was 1 fatal case of disseminated shingles in a vaccine recipient. Again, there was no difference in the rates of relapse or mortality between the participants and historical controls in that peri-vaccination period. Now, this is looking at the use of the vaccine in those with hematological malignancies. Again, this was a randomized controlled trial, this time with 600 patients. The most common malignancy was multiple myeloma, followed by Hodgkin's lymphoma. The incidence of herpes zoster, the vaccine efficacy was 87% with 12 months of follow-up. The anti-glycoprotein E antibody geometric mean concentration and the proportion of participants with a humoral response was lower than in healthy controls, but the T-cell frequencies and the proportion of patients with a T-cell response was similar, interestingly. The percentage with serious adverse events, fatal serious adverse events, relapse or disease progression, and potentially immune-mediated disease was similar in the 2 groups. But it should be noted that patients with non-Hodgkin's B-cell lymphoma or CLL had reduced responses compared with the others. This study looks at the vaccine in those with solid tumours, and it had 232 patients. In this, the most common diagnoses were breast and colorectal cancer. The geometric mean concentrations in humoral vaccine responses were higher in those who received their vaccine prior to chemo than those who got it when they were having chemo at months 1 and 2. You can see in pale in the graph those pre-chemo versus on chemo in darker blue. So at month 1 and month 2, the humoral response was higher pre-chemo, but this difference had been lost later after, by 13 months. The adverse events, the serious adverse events, fatalities, and potential immune-mediated diseases were similar between the groups. The study looks at it in renal transplant recipients. Again, a small study. They found a robust humoral and cell-mediated immune response to IgE. There was no difference linked to which maintenance immunosuppressive therapy the patients were receiving. And once again, the overall occurrences of renal function changes, rejections, unsolicited adverse events, serious adverse events, and potentially immune-mediated diseases were similar between the groups. And this is a study looking at the vaccine's use in people living with HIV. And this study, they decided to give 3 doses of vaccine. However, the responses, both humoral and cellular, peaked after dose 2. There was no further increase after dose 3, as you can see. And so there's no indication really for 3 doses in any group. In those living with HIV, there were no vaccination-related serious events. There was no impact on the HIV viral load or CD4 count. And unfortunately, they didn't look at their responses by CD4 count or if they're on treatment or not. But we know from other vaccine studies that immune response is much better if people have a good CD4 count. Really, their nadir CD4 count is more important than current CD4 count. And also if their immunos got a full viral load suppression. And I just want to digress a little bit and remind you that we just point out to you that we continue to see people, particularly heterosexuals and especially women, who have not had an HIV test, and yet they've presented repeatedly to healthcare with a number of problems, often including shingles as one of those. So please remember to think of testing your patients for HIV. It's a sexually transmitted virus that is, needs to be thought about in all people. That was a little digression, sorry. So to summarize, we know the vaccine is immunogenic and after a hematopoietic stem cell transplant in people with solid tumors, either before or during chemotherapy, in patients with hematological malignancies, in people living with HIV, and renal transplant recipients. And we know the humoral and cell-mediated responses persist for at least 1 year after vaccination, but we will be interested in ongoing data from these studies. And although the vaccine efficacy is reduced in some immunocompromised patients, particularly those hematopoietic stem cell transplant recipients, in these populations with a high risk for shingles and its complications, even a lower dose of vaccine efficacy ensure, the vaccine is still very beneficial. So turning to safety now. So the trials were big trials, and more than 3 million doses of the vaccine were given in its first year of licensure. We know that the adjuvant increases immunogenicity, but it also, with that, increases reactogenicity. The adjuvants specifically stimulate the innate immune system, and that causes a pro-inflammatory response. And that's characterized by increased blood flow and cell migration at the injection site and release of inflammatory mediators into the bloodstream. And so you see local swelling, redness, and pain and systemic responses, such as headaches and mild fever. This is data from the Zoe 70 trial, where you can see in blue the reactions to the Shingrix vaccine versus green placebo. So pain, redness, and swelling. And here you can see the systemic things, fatigue in about 30%, and myalgia, 20% headache, about 10% even shivering, fever, and gastrointestinal symptoms. Importantly, in the studies, serious adverse events and potential immune-mediated diseases and deaths were all equal. This is data from the Australian active surveillance, where people are sent a text message 3 days after their vaccine. They started the vaccine rollout last November, and since then they've had responses from 80,000 people who received Shingrix alone and 13,000 who received it with another vaccine. And I'm sorry, I don't have the key. The blue line is those who received it alone, and the green line, those who received it with another vaccine. You can actually see that the rates of local reaction in the Osvax recipients is considerably lower than in the Zoe study participants, but systemic reactions such as fever, headache, and joint pain are still pretty common, and still those gastrointestinal symptoms and fever are reported. In the Osvax data, less than 1% have seen a doctor after their vaccine, while 6% reported missing work or other activities. After its rollout, there has been some concern about the incidence of Guillain-Barré syndrome, and this is data from the American ACIP meeting in February, February 2021, where they reviewed it, and they felt that there was definitely a temporal distribution of Guillain-Barré cases following the vaccine, as you can see here, and they feel the attributed risk might be around 3 per million doses. Our New Zealand data sheet says the available information is insufficient to determine a causal relationship, but it is something we really do need to consider and remember. Just to summarize the safety and immunocompromise that we have in the placebo-controlled trials, the local and systemic adverse events were increased in vaccine recipients compared with placebo, just as expected from the Zoe studies. But the unsolicited adverse events and serious adverse events were similar between placebo and vaccine recipients, and the potentially immune-mediated diseases, relapses, disease progression, and allograft rejections were balanced between the groups. So this, I believe, is a concern that, of course, many people with a variety of immunocompromising conditions might have, that the vaccine could make their condition worse, but the data we have does not support that. And here you can see a summary of the trials. In orange, the vaccine recipients, and in dark lines, the placebo recipients, and they didn't differ significantly for any group. So now finally, practical issues regarding the use of this vaccine. As I mentioned, it is important that 2 doses are received regardless of previous herpes zoster history or previous receipt of the zoster live vaccine. Ideally, the second dose should be 2 to 6 months after the first, but for people who will be immunodeficient or immunosuppressed, and it's coming up, who would benefit from a shortened schedule, the second dose may be given at a minimum of a month after the first. It can be taken while patients are taking antiviral medications. They won't affect it. I think it's important to warn people how reactogenic the vaccine is, and to encourage them to have dose 2, even if someone has had grade 3 local or systemic reactions. I'm sorry, I did mean to say that grade 3 reactions occur in about 17%, and most of those reactions that I've talked about pass within 1 to 3 days generally. We normally advise a 12-month wait between an episode of shingles, because in that first 12 months, the risk of recurrence is low. However, in immunocompromised people, that may not be true, so they could be vaccinated sooner, but it's important that the episode has resolved, because the vaccine may occasionally cause a flare in symptoms if somebody's not entirely over their shingles. And that's particularly important with ophthalmic shingles, that we don't want to cause a flare. And in fact, we've established with Pharmac that if somebody is not able to receive their vaccine when they're 65 years of age because of ophthalmic shingles and the need to delay it, you can do a NAPA sort of application to Pharmac outlining the reason that somebody couldn't have their vaccine at 65, and they will be able to have it funded a year or so later once their ophthalmic shingles are settled. So practical issues, the timing of vaccines. So those with a hematopoietic stem cell transplant, as I showed you in the study, it can be received earlier if it's autologous, so from 3 to 12 months after the transplant, while for allogeneic, it should be 6 to 12 months later. And it depends on when their prophylactic antivirals are going to be stopped, because you'd really rather give the vaccine prior to discontinuing their antiviral therapy. For solid organ transplants, it's better to administer it prior to transplantation if possible, but if not, give it at least 6 to 12 months after transplantation at a time of stable graft function and during maintenance immunosuppression. For those with immune-mediated inflammatory disease, it should be ideally be given during period of disease control, not during an episode of acute disease or a flare. And if possible, give it prior to the initiation of immunosuppression. And for those receiving anti-B cell antibodies, such as rituximab, it should be given approximately 4 weeks prior to their next scheduled therapy. For cancer, if possible, give it before cancer chemotherapy or immunosuppressive therapy, radiation or splenectomy. And if not possible to do it before, try and give it when the immune system is less acutely suppressed, or when the response is likely to be its best. Now, it's all right to give the Shingrix with influenza vaccine, including adjuvanted. The adjuvants are different, and there has been a study looking at co-administration with that. And COVID vaccines, Pneumovax and Boostrix. And we've recently had released to us a study looking at co-administration with our Vexi, the RSV vaccine, which is adjuvanted with the same adjuvant as Shingrix, but at half the dose. So there's 50 of those each of the immunostimulants in the Shingrix vaccine, but 25 micrograms in the Vexi. And they've just completed this study and have concluded that they can be given together, preferably in separate limbs. Up until now, we were saying that because of it being the same adjuvant, we wouldn't think they should be given together. But there's a slight caveat. Reactions will occur more frequently when they're co-administered than if they're given separately. And you can see that here in purple bars are those who received shingles vaccine with our Vexi, and in green, they're just getting the shingles vaccine by itself. So these things like headache and fatigue and myalgia are more common when you give the two vaccines together. So it's kind of a decision to make whether somebody wants to have them together or is able to space them out. I want to remind you that other vaccine preventable diseases are important in this patient group. They have an increased risk of morbidity from multiple vaccine preventable diseases and are recommended and funded to receive them. I've concentrated on herpes zoster protection in this webinar because of the recent change in funding. But pneumococcal, influenza, and COVID vaccines are all funded in these patients and should be encouraged. And while RSV is not funded for any groups yet, the risk of severe disease is increased in those with immunocompromised, particularly groups like hematopoietic stem cell transplant recipients. Whoops, I just wanted to say one other thing on that slide. I just wanted to remind you that your elderly patients, your 80-year-olds and 90-year-olds have a very high risk of shingles. And it would be great if they could get the vaccine, or if you can think of innovative ways to get it for them. Finally, I just want to point out to you that we have fact sheets for various immunocompromised groups available on the IMAC website, which talk about all the vaccines, including shingles vaccine for these groups. And Australia is just increasing their funding for shingles vaccine to immunocompromised groups. And their document about that has an appendix, which has a great list talking about all the different conditions that can increase and all the medications that can increase the risk of shingles. So if you want to see if one of your patients is at risk of an increased risk of shingles, that's a great document. It doesn't mean they're funded. I've talked about who we have funding for here. It's a different issue. So finally, those with immunocompromised have increased rates of herpes zoster and a higher rate of complications. The recombinant adjuvanted vaccine is effective in people without immunocompromised for 50 years, including those who are elderly and who have comorbidity. And we have limited studies in those following hematopoietic stem cell transplants, solid organ transplants, hematological malignancies, cancer, and people with HIV, which show good immunogenicity and efficacy, but it's slightly reduced. But because of the high risk of shingles and its adverse effects, we'd certainly recommend vaccine for all immunocompromised, and it's funded for some. Remember, it's reactogenic, can cause local and systemic adverse events, and people might need encouragement to have their second dose. And if you have queries, you're always welcome to ring IMAC to discuss if it's sensible to proceed with a second dose with anyone, or any other questions related to vaccines. Importantly, there's no evidence of disease progression or an increase in immune-mediated events in the immunocompromised studies performed. However, we do need to remember there's a potential signal of an increased risk of Guillain-Barré syndromes, and this was a non-immunocompromised group. And it's just one of a number of vaccines that your patients with immunocompromise are recommended to have. So thank you.
Wonderful. Thank you, Joan. That was awesome. So we have a question that, does the definition of immunocompromise include chronic mental illness like complex PTSD?
So I'm happy to answer that, Joan.
Great.
Yeah, so there is a little subgroup called of immunology, a little study group, which is psychoneuroimmunology, which is a whole group about stress and the effect of stress on the immune system. So while there is a lot of research, it doesn't actually get to the level of immunocompromise that we are showing you today, that would make it easily fundable for things like Shingrix. So that's why they are not necessarily funded, because they're not high on the list of groups. But that the effect of stress on shingles is well documented. Yeah. Does that answer some of that?
Yeah, absolutely. So I guess they might be people that, if they were to ask, we could recommend that they self-fund, because they would be
absolutely, yeah.
Okay, awesome. If someone is vaccinated against varicella and then doesn't get chickenpox, could they still get shingles?
Yeah, so they can still get it from the vaccine itself, potentially, because that's a live vaccine, but at a lot lower rate. Yeah.
Joan, you mentioned the time frame for the second dose is kind of ideally 2 to 6 months, or possibly shorter if they're immunocompromised. What's the latest time frame that a second dose could be given that it would still be effective?
Well, we never say you have to restart a vaccine series, really. So, yeah.
So even if it was a year or two, they could still go on and get their second dose. Okay.
Definitely.
Sweet.
Yeah, even if they've had their 3-month vaccines many, many years ago, at least they've started their vaccines.
Cool.
Yeah.
There were a lot of clinics that encouraged a lot of their 65-year-olds to get Zostavax, especially during COVID. If there's a group of patients that have had Zostavax around the time they were 65, and now that Shingrix is available, should we be recommending that they self-fund Shingrix even though they've had Zostavax?
Yeah, so we're really, really keen for Pharmac to start fund some of these people because as Zostavax especially does wear out with time. It's not a particularly fabulous vaccine like Shingrix, but so it's now not available. It was the only one available at the time, and it was helpful. But now the really good thing about Shingrix is that could actually boost their immunity, and be quite helpful later on. But they're not yet funded. Yeah. Yeah.
But if they want to fund, and it's, some years since their Zostavax, we know after 5 years it's really not very effective at all. So
yeah,
it's well worth having a Shingrix, even if they've had a Zostavax.
Awesome.
But make it two. Make it two.
Yeah,
two.
Yeah, correct. Yeah.
Almost two. Cool. Along a similar vein, if someone has had Zostavax before, we're going to example here of, say, someone who had Zostavax at age 80, and now they're 87 and they have become immunocompromised and been put on something like methotrexate, would they be funded for Shingrix now?
Yeah, if it was a rheumatoid arthritis or a
SLE or
SLE, yeah, or a polymyalgia rheumatica, then you're sorted. And that is the vast majority. But unfortunately, that's such a big group. So that's why we've struggled to get funding for every single form of autoimmunity.
But certainly people with the immunocompromising conditions at older age groups are eligible.
Yes, very high risk because they've got the age as well as the autoimmunity as well as the immunocompromising or immunosuppression.
And if someone's immunocompromised not meeting those specific conditions, presumably they can still self-fund that.
They can self-fund, yeah.
Available. Okay, great. You mentioned, Joan, that the vaccine should be given at least 4 weeks before someone starts anti-B cell monoclonal antibody treatment. Why is that?
I think it was when people are on it, 4 weeks before the next dose is the recommended time. They're very immunosuppressing the B cell monoclonal antibody therapies. They really impact B cell responses. Yeah, so I mean, ideally before starting them, but once you're on them, do it 4 weeks before the next dose because the effect will be less and it gives time for you to respond to the vaccine before your next dose.
We often have to do really individualized treatments to try and regimes to try and maneuver it so that we're optimizing their immune response, but they're so immunosuppressed we know that it won't be their full immune response, especially because you're optimizing all the different conditions as best you can. So the risk of further disease versus the vaccine versus the effect of the vaccine, as well as the immunocompromising or the immunosuppression that you're giving them. You see what I mean?
If someone above the age of 18 has not been vaccinated against varicella and has never had varicella, has negative immunity confirmed on their blood, so they certainly haven't had varicella, would Shingrix prevent a primary varicella infection?
Oh, dying to know. There's no data. Dying to know this. Very, very, very interesting question. There's no data out yet, but apparently the companies are doing the studies.
Okay, so TBC. Since the varicella vaccine was introduced in the childhood immunisation schedule, when would the effect of that likely to be seen in terms of preventing shingles down the track?
Well, we're seeing a clear reduction in chickenpox. It's a shame we don't give 2 doses, but we are seeing impact on pediatric disease. So I mean, it's only a matter of time, I suppose, before people start aging. Yeah, it will take a while, won't it? What do you think, Edwin?
Yeah, it would be nice to add in that second dose sometime, so you're supposed to really have a dose at 7 months and at around a year or 15 months ideally, and we've only got one funded dose, so that would be really good to start to introduce so that we're putting more pressure on getting rid of varicella out of our community.
Is that in the pipeline at all to introduce a second dose?
I've seen it on a list, but it's way down on the priority list.
I'm sure there's many, many things on that list. So for someone that is immunocompromised that meets the funding criteria, is it something that they should get kind of as soon as they're eligible? And if so, how often should they get the Shingrix? Is it kind of just a one-off that's funded, or should it be every 5 years or 10 years if someone's immunocompromised?
If you've come up and you're funded, then it's highly, highly recommended you get it. Yeah, that's one thing, especially it's your 66th year, in your 65th birthday. That's a really, really good time to consider your Shingrix. What was the other part of the question?
Well, whether to give further doses at this stage.
Well, the
just
long-term
primary
data is
series.
fantastic. Yeah, long-term data is fantastic. Sorry to interrupt, Joan. Yeah.
No.
Yeah.
So at this stage, repeat doses aren't yet
Unnecessary.
kind of needed or supported.
But I mean, if we're giving it a lot to people in their 20s because they're severely immunocompromised, who knows in the future? But at this stage, we've got good data, good protection out to 10 years in healthy people. Yeah.
If someone has had Guillain-Barré syndrome in the past, hopefully I'm saying that right, that's always a tongue twister, does that increase their risk of Guillain-Barré post-Shingrix vaccine that we know of?
That's a hard question to answer because it's such a rare issue. When I'm thinking of, say, influenza vaccine, the only reason we wouldn't give an influenza vaccine to somebody was if their previous somebody who's had Guillain-Barré before, was if their Guillain-Barré syndrome was brought on by an influenza vaccine. And even then, it's not a total contraindication, it's a risk-benefit discussion. So I would think for somebody who's already had a previous episode of Guillain-Barré syndrome, which will be not related to the vaccine, presumably, because we haven't had the vaccine for that long, that it's a risk-benefit discussion. I think we'd say to them, there are many benefits to you from having the shingles vaccine, and we don't know whether you might be slightly more likely to have Guillain-Barré after it than people who haven't had Guillain-Barré before. But on balance, probably the benefits outweigh that very slight risk, and let that individual be aware of the risk and be part of the decision making. What would you say, Edwin?
Yeah, and just to add to that fabulous answer of Joan's, I think you've got a much, much higher risk of Guillain-Barré from the wild type infection than you have from any vaccine. Yeah. So I'd be more nervous of Guillain-Barré from zoster infection than I would be from Shingrix.
Someone was asking here for cancer patients whether oncology departments might be able to vaccinate their patients directly with Shingrix. I don't work in oncology, so I'm not sure.
They're not really funded, though.
I don't work in oncology either, but that'd be nice if they could, but I don't think they do. And I think they try to avoid vaccines when they're under active treatment anyway. Yeah.
I wonder if before they were to start, whether the oncology departments might be able to opportunistically.
I mean, that would be fantastic. Yeah, or go and see their GPs about it.
For immunocompromised people with shingles itself, is their infectivity period longer than someone that's not immunocompromised?
Well, it may be, because you're potentially shedding the virus while you've got uncrusted lesions. So if their lesions persist for longer, or they have more lesions, they would therefore be a bit more infectious. Yeah.
And do the antivirals to treat shingles itself, do they reduce the period of infectivity?
I think they hasten resolution and crusting and shorten the duration of getting new lesions, so therefore reduce the period of infectivity. Yeah. But it's just the rash that's infectious. You know, it's much less infectious than chickenpox.
Do we continue with prophylactic valacyclovir post-shingles vaccination?
Hematopoietic stem cell patients are given prophylactic acyclovir, antivirals to try and prevent herpes viruses. And I think you would, once you've had the shingles vaccine post a hematopoietic stem cell transplant, you could stop that prophylactic antivirals, provided it's the timing, there are many factors they consider before stopping antivirals. But yeah, shingles isn't the only risk. There's other herpes viruses that they're at risk of. So yeah, I'm not sure which other groups that questioner was thinking of.
And again, back to varicella, if we've got an immunocompromised adult with never had chickenpox and not had varicella, they're just asking here, should we go ahead and give Shingrix anyway, because it might be better than nothing if they can't have the live varicella vaccine?
You'll notice if you've studied some of our special immunisation schedules that we're actually recommending for the hematopoietic stem cell transplant patients, that they have their Shingrix. They can have it quite soon after the transplant, but for a live vaccine they can't. They've got to wait 2 years. Yeah, so they would have their Shingrix before they had their varicella vaccine if they were under 50. Yeah, so that was kind of a bit of an unusual situation. But so would we do the same in this situation? It's a real unknown, but it's kind of the sort of thing we'd be recommending.
Is primary adrenal insufficiency covered for this funding? I think from what you've said, probably not. Joan, you're shaking your head. Someone just commented here that in North America they've said that these patients shouldn't have live vaccines. They're not covered under the funding.
I don't think that's a problem. I don't think that's a problem at all. Yeah. No, I would still be betting on, even with the live vaccines.
Quite a small group.
Yes.
We've got a question again around funding. Is it funded for patients waiting on chemo or radiation therapy for breast or bowel cancers?
No.
Yeah, so it's post chemotherapy, but if you can get it for them because they're going to have that chemotherapy, then I don't see a problem with trying. But it's supposed to be post chemotherapy.
But I don't think it is chemo, is it?
Well, it depends on the So the chemotherapy is actually you mean for this is for Shingrix?
Yes, if they're hematopoietic stem cell transplant or hematological malignancies, but not chemo for solid organ, unfortunately.
Yeah.
Okay.
Yeah.
No.
And if someone has had a sorry, what was it, Ingram?
Yeah, sorry. Sometimes I've got them at. Yeah, but it just depends on the situation.
If someone's had a stem cell transplant years ago, like 20 years ago, and they've been well since, should they have Shingrix?
They still qualify. I'd consider it. Yeah, because age is also a risk factor.
And there's a couple more questions coming in around funding. I think in your slides, Joan, as well, there was a bunch of IMAC links, including some stuff around people at increased risk and maybe some funding things there.
One thing I just want to say, for people with hematological malignancies such as Hodgkin's disease that's considered cured 10 years ago, then they wouldn't be. I think, for something that's cured, like Hodgkin's, I think would say in the last 2 or 5, if it was more than 2 or 5 years ago, probably their risk is not so elevated, obviously.
And the immunisation handbook's all available online. It's got a good section, I think, about specifically outlining funding criteria for all of the patients. So we probably don't need to nut out all the funding queries tonight, when there's a great resource for that.
And there was a New Zealand doctor article just published, I believe, by Mary Nolan from IMEC on this subject of zoster vaccine for immunocompromised.
Oh, great.
In the New Zealand immunisation schedule handbook is actually updated quite regularly now. It's every 2 to 3 months. Yeah.
Oh, wonderful. Cool.
Yeah.
So that's all kind of hot off the press stuff.
That should be your Bible.
Awesome. Cool. Great. Well, we've answered heaps of questions. I think I've learned a lot, and your talk was awesome, Joan. And thanks, Edwin, for your wisdom during the Q&A. That's been a really good session. So thank you, everyone, for attending. Thank you, Joan and Edwin, for all your wisdom and experience shared with us tonight. We really appreciate it, and look forward to seeing all the attendees at more Goodfellow webinars later in the year. Thank you so much.